Emergency physicians are frequent providers of Indigenous health, and this can be a highly rewarding part of our work. Some find the complex determinants that affect patients' presentations to be difficult to manage in the fast-paced ED setting. This can be compounded by the episodic nature of the ED visit and a number of challenges that originate upstream from the emergency department. However, because of the degree of marginalization that Indigenous Canadians face, any improvement in care has the potential to result in large gains. We will focus on one issue that has a significant impact on Indigenous health, which can be tackled through the ED at the provider level starting today. We will be exploring the issue of implicit bias. This presentation was produced on the traditional and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations. As the producer of this video, I do not possess any lived experience from an Indigenous perspective, as I am an Asian settler. I do not have any additional conflicts of interest to disclose. It is widely known that Indigenous Canadians have poorer health status compared to non-Indigenous Canadians. For example, life expectancy for all Canadians is 81.7 years at birth. For Indigenous Canadians, this is 75.7 years. There's a 6-year gap, and this puts the life expectancy of Indigenous Canadians on par with that of Hungary, which is well below the OECD average of 80.5 years. Other markers of health status includes neonatal death, as well as mortality after myocardial infarction, diabetes, as well as suicidal ideation. All of these are higher amongst Indigenous Canadians. This illustrates an entire population within Canada that is reaping limited benefits of the advanced societal and healthcare infrastructure that we have. It is well known that the determinants of health contribute to performance on health status indicators. Indigenous Canadians are systematically disadvantaged across almost all determinants of health, proximal, intermediate to the distal, in a dramatic demonstration of structural violence. We'll illustrate one example here using income, which is one of the strongest determinants. You'll see on the graph here that the gray bar represents First Nation Canadians in First Nation communities. The green bars represent the total Canadian population. There's almost a linear negative relationship between increase in income bracket and the decreased number of First Nations Canadians in each bracket as you go towards screen right. This is clearly not the case with the green bar representing all Canadians. In addition to the increasingly well-known trauma around residential schools and the 60s scoop, there are other examples of historical injustices that were perpetrated by members of the healthcare system. The Indian hospitals were created to treat specific diseases such as tuberculosis. However, essentially they functioned as quarantines. Poor experiences and reports of abuse contribute to lasting distrust of the medical system. In addition, the nutritional deprivation experiments were performed by government researchers between the 1940s and the 50s in order to identify the effects of malnutrition. This involved at least 1,300 Indigenous children, and one of the sites that were used was Port Alberni. Trauma and injustices from within the healthcare system is not limited to the past. The death of Mr. Brian Sinclair in an ED waiting room in 2008 after waiting for 34 hours resulted in an external review, which included numerous recommendations to address racism in healthcare. In 2017, an external review found that there were reports of women being offered tubal ligation during active labor, or women reporting that they were not advised that tubal ligation was permanent. This report cited that racism was a factor. There's also evidence of explicit racism demonstrated by physicians. Pictured here, you see a woman holding up a prescription with a drawing of a beer bottle that's been crossed out. This was a prescription that she received thinking that this was a genuine prescription for her abdominal pain. This was given to her folded up, and she didn't discover this until she returned home. These occurrences have the potential to affect the degree of trust towards the medical system for each of our patients. In addition to the health status and the determinants of health we have just discussed, Trauma also play a role in the presentation of the patient. The prolonged exposure to past, present, and possibly intergenerational trauma have contributed to what is now becoming termed complex PTSD. We will not go into details with regards to trauma other than to mention that many of the manifestations can be misattributed to personality disorders, which may cause further stigmatization of the patient. Your patient's presentation may be affected by multiple factors. First, a higher pretest probability of disease may be the case given the adverse health status. In examining the determinants of health, there may be multiple risk factors at play. Your patient may also have experiences that impair their trust towards medical professionals. And finally, your patient's experience may include trauma, which may affect their presentation. It then becomes incumbent on the emergency physician to have a higher index of suspicion, as well as to have an effective and efficient demonstration of cultural sensitivity in order to build therapeutic alliance in a time-limited setting. As emergency physicians, we're in a position to alleviate health disparities or potentially perpetuate or even contribute to it. So what is the experience like for Indigenous Canadians in the emergency department? Surveys report a perception of lower quality of care received. Other qualitative studies report that patients feel judged on the basis of their socioeconomic status, the legitimacy of their pain, or the perception of inappropriate reasons for presentation. Here are some quotes from qualitative studies. I don't really like coming to the emergency department, but where's a guy supposed to go, you know? And again, is it because I maybe look like a street person? Maybe it's because I'm native. I don't know. They treated me like crap, and I know it was because I was native. We all know because of the look. There is a look. When you need the medical care, we put up with it. We shouldn't have to. We bleed the same way, we birth the same way, we have no choice. Regardless of what the actual occurrences were in these healthcare encounters and what caused them, even the perception of unequal and discriminatory treatment can further damage therapeutic alliance. This begs the question, is there any objective evidence of disparity in the healthcare that is offered in the emergency department? In the United States, there is. There are studies demonstrating racial disparity in emergency department length of stay, analgesia for appendicitis, rates of lab and radiographic testing, triage acuity scores, and leaving the ED without complete care, amongst many other topics. There are very few studies in Canada that examine this topic. One study in the Canadian Journal of Emergency Medicine this January 2019 examined patients presenting with abdominal pain with a CTAS score of 3 in looking at two markers, time to physician and time to analgesia, between First Nations individuals as well as non-First Nations. No statistically significant differences were found in either of these markers. However, there were several limitations. There was a difference in the number of people who left without being seen, 8% in First Nations and 0% amongst the rest of the studied population. The proportion who left without being seen is increasingly being used as a marker for quality of care. And as well in this study, the mean wait time for those who left without being seen was higher than the mean time for those who completed their visit. In addition, First Nations individuals were identified in the study using status. This can potentially misallocate people. Finally, there's evidence that non-majority races receive slightly lower triage scores, which was alluded to in the previous slide. So to put this into context, this is one data point, although it is somewhat reassuring. Examining the issue of racial disparity in healthcare in the United States, the Institute of Medicine recognized implicit bias as a contributor. Implicit bias are stereotypes that unconsciously affect our individual understanding, actions, and decisions. It allows one to create favorable or unfavorable assessment without one's conscious control or awareness. This is different from explicit bias, which is usually under conscious control. Implicit bias has certain advantages. It allows people to make efficient decisions, as well as it allows for cognitive offloading by automating certain decisions. There is evidence to suggest that the emergency department environment is conducive to implicit bias. Activators of implicit bias include fatigue, time constraint, information overload, and being required to make quick decisions with limited information. This probably sounds a lot like the usual emergency department environment. One study found that there was a significant association between ED overcrowding and higher post-shift implicit bias. In examining the literature studying racial disparity and implicit bias, there are a number of limitations. There are very few studies examining healthcare disparities affecting Indigenous Canadians. Most racial healthcare disparity studies are done in the United States or Australia. Implicit bias is a growing area of study. Very few studies correlate implicit bias directly with health outcome, and many studies are done outside the ED setting. However, the vast majority of studies show evidence of a pro-white bias among healthcare professionals. The level of bias is similar to the general population, and in study assessing correlation, most found a positive correlation between level of implicit bias and lower quality of care. To examine this further, we'll broadly break down the impact of implicit bias into three categories: communication, medical decisions, and health outcome. I will be using the words such as white and black to indicate race, as I did in the previous slide. This follows word usage in racial bias literature, and I would not necessarily advocate for the use of these words outside of these contexts. Most studies measured implicit bias using the implicit association test. A brief summary is that it uses reaction time to determine the strength of association between concepts, such as white, black, good, and bad. It is reported to have good psychometric properties. Some criticism include that it is possible to be faked, and in some versions it finds bias in almost everyone. The domain of healthcare that is most affected by implicit bias is communication. In one study, explicit bias was found to affect the content of conversation, while implicit bias affects the nonverbal forms of bias, such as eye contact, mannerisms, and speech errors. One study examined the impact of implicit bias on clinicians as they interacted with white patients versus black patients. For clinicians with a higher degree of pro-white bias, while they encountered black patients, they demonstrated a higher degree of verbal dominance. They were also less likely to be liked by their patients. Their patients are also to have lower confidence in them, and their patients are also less likely to recommend them to other patients. When these clinicians interacted with white patients, their patients have a higher likelihood of perceiving that they were treated with respect. Their patients were also more likely to believe that they're liked by their clinicians. However, there's a lower likelihood that their patients find their encounter to be participatory. So in general, pro-white bias favors white patients. However, clinicians with a higher degree of implicit racial bias also had one adverse impact on white patients in that they are generally viewed as being less participatory. Interestingly, discordance in explicit and implicit bias is associated with less positive interactions. Clinicians with a low degree of implicit and explicit bias are obviously perceived very well by their patients. Interestingly, the group of clinicians who are perceived the worst by their patients are not those clinicians who demonstrated a high degree of explicit and high degree of implicit bias. Instead, it is clinicians who demonstrated a high degree of implicit bias while having a low degree of explicit bias, which suggested that patients are able to detect implicit bias regardless of what is outwardly spoken in the content of the conversation. In a study of implicit bias amongst oncologists, bias is negatively associated with perceived oncologist communication, patient reaction to the interaction, as well as patient perception of the recommended treatment. Interestingly, these ratings were similar between patients as well as external observers, which suggests that bias can be perceived by third parties. There were no significant difference in the degree of patient involvement in decision-making, but patients still had less confidence in the recommended treatments. In summary, there is fairly clear association between pro-white clinician bias and poor perceived communication by patients. Due to our dependence on communication to obtain a history and the potential impact of communication on adherence, impaired communication has the potential to cause significant impact even if all other aspects of care were not adversely affected by bias. There are fewer studies examining the link between implicit bias and medical decision-making, and the results are more mixed. We'll take a look at some of these studies. When primed with faces of Black people, physicians reacted more quickly to stereotypical diseases. These were not limited to genetically predisposed diseases such as sickle cell, but also to conditions such as obesity and substance use. Under higher time pressure, physicians with higher degree of implicit bias against Black and Hispanic people gave less serious diagnosis to these groups. They also had a lower rate of referral to specialists. As pro-white bias increased amongst a group of pediatricians, their rates of prescribing narcotic medication decreased to African American patients, but not for white patients. In one study, physicians with a higher degree of pro-white bias had a higher likelihood of treating patients who are white, but not Black, with thrombolysis in clinical vignettes depicting typical myocardial infarction presentations. Overall, there is some evidence that implicit bias affect medical decision-making. It is important to note, though, that there are also a number of negative studies on the association between implicit bias and medical decision-making. Most studies were also done by vignettes rather than real-world subjects. There are few studies examining the link between implicit bias and health outcome. In counties with higher implicit prejudice, Black mothers experience a higher rate of preterm birth as well as low birth weight compared to average rates amongst Black women. Greater physician implicit bias was associated with disability amongst individuals with spinal cord injury in the form of social integration, depression, and life satisfaction. There were no association found with physical health outcomes. To summarize the state of the evidence, there is consistent evidence of pro-white bias among health professionals on systematic reviews. The level of bias is comparable to the general population. There is fairly clear evidence that implicit bias adversely affects communication. There is some but inconsistent evidence that implicit bias affects medical decision-making, although this is shown primarily through vignette studies rather than real patients. There are very few studies that directly investigate the link between implicit bias and health outcome. The results are also fairly mixed. There is fairly good consensus that the role of implicit bias in health disparity is a growing area of study. Zooming outside the world of physicians, there's also clear evidence of pro-white bias amongst nurses. Interestingly, there are also evidence that non-nursing and non-physician health workers demonstrate more pro-white bias than physicians and nurses. It is therefore possible or even likely that before the patients get to the physician, they have already experienced implicit bias. Patients may also be presented to physicians through the lens of implicit bias by other providers. In summary, the healthcare experience of Indigenous patients can include a number of barriers. The four that we have discussed here today include: number one, given the poor baseline population health status, adverse health determinants, historic and ongoing oppression, and the manifestation of trauma, Indigenous patients presenting to the emergency department likely warrant additional attention and consideration. 2. Indigenous patients have reported poor experience in the emergency department. 3. There is evidence of racial health disparity. And 4. There is evidence that implicit bias negatively affects care, mostly in the domain of impaired communication based on presently available evidence. We will now examine what an emergency physician can do in the ED setting to improve care. We'll subdivide strategies into two categories. Point of care strategies are immediately applicable and can be tried on your next shift. These strategies do not seek to reduce bias, but seek to mitigate their impact. Comprehensive strategies are more meaningful over the longer term. These strategies do seek to alleviate bias over time. But first, maybe we should each start by taking 40 milligrams of propranolol and going suntanning. Evidence shows that 40 milligrams of propranolol can decrease the degree of racial implicit bias. Also, visualizing ownership of a darker skinned body has been shown to reduce implicit bias. While it's unlikely that we'll be rolling out these strategies across emergency departments, they do suggest interesting neurological pathways involved in bias and potentially yield more ways we can target and refine our interventions in the future. The first point-of-care strategy that we'll talk about are cognitive forcing strategies. We'll start by assuming that implicit bias is present in each of our encounters with Indigenous patients. We will then force ourselves to ensure that the effect of the implicit bias has been mitigated. We already use these positive identification strategies in medicine. For example, in the operating room, surgeons often identify structures that they do not want to cut into and protect it before proceeding with surgery in order to prevent injury. In the emergency department, we often identify structures such as the liver or arteries prior to performing procedures in the relevant areas. This does not necessarily imply that one is a bad proceduralist who is prone to injuring these structures. Similarly, identifying that implicit bias may be present does not identify one as a racist. It merely anticipates and lowers the risk of problems and injuries. Another strategy is individualization. This focuses on seeing each patient as a unique individual rather than a representative of a population. This could be done by focusing on the social history or by involving family members. Essentially, it reminds us that the only things that we know about a patient is what she or he tells you. Even the things we talked about today are generalizations, and they may or may not apply to the patients that are in front of you. Ask who your patients are and what their experiences are. The next strategy is known as stereotype replacement. Here, we recognize some of our responses towards patients as being stereotypic. For example, using limited testing or anticipating poor adherence, or using non-patient-centered communication style. Once we recognize this, we remind ourselves to replace this with a more favorable response, such as viewing this as an opportunity to address existing health disparities, or viewing this as an opportunity to mitigate risk factors and poor health determinants. In this case, we are seeing race rather than not seeing race. We're using race as a cue of an opportunity to address the 6-year gap in life expectancy that we discussed earlier. Next, we'll focus on communication. We can do this by committing to using a structured approach to enhancing patient-centered communication. This could be through acronyms such as the FIFE approach or any other acronym of your choosing. This may seem quite basic. However, we likely use good communication skills with patients who we already have excellent rapport with or who we feel more empathy towards. And based on the studies we looked at earlier, these are less likely to be patients who are Indigenous due to our likely implicit bias. And hence, even if there was equality in the sense that we don't use a structured approach such as FIFE on any of our patients in the emergency department due to time constraints, there will be an inequity of the effect, which disproportionately affects the Indigenous patients. We already do this in some of our practices. For example, in pediatrics, people use the HEADS assessment. And the reason why people do this is that we all know that it is difficult to talk about violence or about sex with teenagers. However, we also know that there are higher prevalence of issues affecting those specific risk factors. And so using a structured approach such as the HEADS assessment forces us to have those conversations and to mitigate those risk factors. We can use the same approach to selectively enhance our communication with Indigenous patients using structured communication tools. Next, we'll take a look at some of the more comprehensive strategies, such as increasing meaningful interactions. We can start by making meaningful friendship with people outside our own demographic, keeping in mind that this is a gesture of respect rather than tokenism. We're aiming to develop healthy respect and admiration for people who are outside our own demographic. This provides us with an opportunity to develop counter-stereotypic imaging. If we don't have meaningful contact with Indigenous people in our own personal lives, our impression of what an Indigenous person is like would be essentially based on movies, stereotypes, and seeing patients at their most vulnerable times when they present to the emergency department. Inherently, physicians treat patients to an imaginary endpoint of what the patient's health status is like prior to coming into the emergency department. This becomes difficult to do if one cannot imagine an Indigenous person who is well, dignified, and high-functioning based on the common stereotypes that we see. It is therefore absolutely essential that we develop counter-stereotypic imaging and to be able to visualize people at their best. The next strategy is perspective taking. This involves trying on the lens of our patients. This could be done in many different ways, but I think that it is essential for us to understand the oppression and the injustices that have been faced by Indigenous Canadians both historically and presently. There is some evidence that bias is worse when providers view patients as being responsible for their own health problems. Understanding the historical trauma, previous and current oppressions would help alleviate this problem. Additional training may enhance our competencies in working with marginalized populations. These can include trauma-informed practice or cultural safety and cultural humility training. There are numerous options for pursuing these, and the resources listed on the slide are just a few examples. In conclusion, emergency physicians are frequent providers of Indigenous health in Canada. This provides us with a unique opportunity to alleviate health disparities and potentially address the 6-year life expectancy gap. However, the emergency department is highly predisposed to implicit bias, and emerging evidence suggests significant impact on patient care. As communication and therapeutic alliance are the final converging points of everything we know and do in medicine, it is crucial that we address any barriers affecting this juncture. By acknowledging our bias and by making a conscious effort to mitigate its impact, we have an opportunity to make a true contribution to reconciliation. Thank you.